Have you ever woken up, like, completely aware of everything around you, but found yourself just frozen, can't move, can't speak?
Hmm.
Maybe you even felt a real weight on your chest or sensed someone
Yeah.
or something else in the room.
It's a really unsettling feeling for people who experience it.
Absolutely terrifying for men,
Yeah.
yeah. And it's got a name,
Yeah.
sleep paralysis.
Right.
And here's where it gets, really fascinating. This isn't some new thing.
Oh, definitely not.
For centuries, people all over the world have had these experiences.
Mm-hmm.
And they've interpreted them in, well, some pretty wild ways, drawing on their own cultures and fears.
Everything from demons and spirits.
Yeah, night hags, that kind of thing.
Yeah.
Right up to, more recently, you hear stories about alien abductions.
It really taps into primal fears.
It does. So our mission in this deep dive is to take all these sources you've shared, the articles, the studies, the reviews, and really pull out the key pieces.
Get to the core of it.
Exactly. We want to figure out what sleep paralysis is, the science behind why it happens, why it feels so incredibly real and, frankly, frightening.
And who tends to experience it? What makes someone more prone to it?
Right, who's more likely? And crucially, how can you manage it if it happens to you? Plus, we'll look at how different cultures have tried to make sense of it over time. What stands out most to you about this whole phenomenon?
For me, it's that incredible intersection of biology and perception. The basic physical event might be universal, but how we experience it, how terrifying it feels, that can be so different based on context and belief.
That's a great point. Okay, so let's start there with the basics from the sources. What exactly is sleep paralysis?
Fundamentally, it's defined as this temporary state where you just can't move your body or speak.
And it usually happens at specific times.
Yeah, typically right as you're waking up, that's called hypnopompic sleep paralysis. Or less often as you're falling asleep, which is the hypnagogic type.
The key thing being,
Mhm.
you're awake.
Yes, that's the defining characteristic. You feel fully conscious, aware of your surroundings, but your voluntary muscles are, well, paralyzed. Except, crucially, for your eyes and your breathing muscles.
So you can look around, and you're breathing okay, but you can't move a limb or call out.
Precisely. It's that disconnect that's so jarring.
And the sources classify this, right?
Right.
It's not just some random event.
No, it's categorized. It's a type of parasomnia. Those are unwanted events that happen during sleep or the transitions in and out of sleep.
Like sleepwalking or night terrors.
Similar category, yes. But sleep paralysis is specifically labeled a REM parasomnia.
Because it's tied to REM sleep, the dreaming stage.
Exactly. It's intimately connected to the physiological processes that happen during rapid eye movement sleep.
Okay, so how long are we talking here? Because when people describe it, it sounds like it lasts forever.
Subjectively, I'm sure it feels that way. But typically, episodes are quite brief. We're talking seconds, maybe up to a couple of minutes, usually. Well, some reports, like those mentioned in the sources, do describe episodes stretching out, maybe even up to 20 minutes, which you can imagine would be incredibly distressing.
20 minutes, wow. Does it just stop on its own?
Generally, yes, it resolves spontaneously. But sometimes an external stimulus, like someone touching you or hearing a sound, can break the spell, so to speak.
Okay, so how many people actually experience this? Is it common or pretty rare?
It's surprisingly common, actually. The sources suggest around 8% of the general population, so maybe 8 out of 100 people will have it at least once.
8%. That's quite a few people.
It is, but here's where it gets tricky. Those prevalence estimates, they vary wildly in different studies.
How wild.
Like anywhere from 5% up to 40%. There was one big meta-analysis looking at over 167,000 people across 25 countries,
Okay.
and it found a global prevalence closer to 30%. So the numbers are definitely all over the place.
Whoa, 5% versus 40%, that's a huge gap. What's going on there? Why such a difference?
That variation is really interesting, and the sources suggest it's not just about the biology. It points to how cultural factors, especially the level of fear or the type of explanation associated with it, influence whether people recognize it, label it, and then report it.
Ah, so if your culture tells you it's, say, a ghost attack, you're maybe more likely to notice it and talk about it than if you just think it's a weird sleep thing?
Exactly. If it's framed as something deeply frightening or significant, it might get reported more readily. Fear can amplify the perception and reporting.
That makes sense. When does it usually start for people?
Onset is often in adolescence. It seems to be most frequently reported between the ages of 20 and 40. But really, the sources are clear. It can affect anyone, any age, any gender.
Okay, so let's really get into what it feels like for the person experiencing it. beyond just being frozen.
Right, the subjective experience. The sources are very consistent here. The overwhelming emotions are profound fear, panic, and this feeling of utter helplessness.
Because you're conscious but can't react.
Precisely. You can't move, can't scream, and then there's often a distinct physical sensation.
The pressure.
Yes, that intense pressure on the chest. People describe it as feeling like they're being choked or suffocated or like something incredibly heavy is just sitting on them.
Which would definitely contribute to the panic.
Absolutely. And then layered on top of that are the hallucinations.
Which are super common.
Sure.
And often pretty terrifying.
Extremely common and, yes, often very frightening. They can be auditory hearing, things like buzzing, footsteps, voices, visual seeing figures, shadows, lights, or even tactile feeling like you're being touched, pushed, or pulled. And they feel incredibly vivid, very real.
The sources actually break these hallucinations down into a few types, don't they?
They do. There are what they call intruder hallucinations. That's when you perceive some kind of dangerous presence, a person or an entity, there in the room with you.
Okay, that sounds scary enough.
Then there are incubus hallucinations. These are directly linked to that feeling of chest pressure and suffocation, the sense that the perceived intruder is actually pressing down on you, choking you.
So the feeling and the perceived presence are often connected.
Very often, yes. They seem to go hand in hand frequently. And then there's a third category, which is a bit different, vestibular motor disorientation.
Vestibular motor. What does that involve?
That covers sensations like feeling like you're floating or spinning or falling, or even more strangely, feeling like you're moving out of your physical body.
Like an out-of-body experience.
Exactly. Or seeing yourself from a distance, maybe from above.
That's bizarre. And the sources noted something interesting about how the brain reacts differently to that last type.
Right. It seems those vestibular motor types, the floating or OBEs, don't typically trigger the brain's threat detection system, that threat-activated vigilance system, quite as intensely as the intruder or incubus types do.
So maybe they feel weird or disorienting, but not necessarily as acutely terrifying as feeling like you're being attacked.
That seems to be the thinking, yes. The perceived level of immediate danger is different, but fundamentally, all these hallucinations are described as being like vivid dream content spilling over into wakefulness.
Okay, that's a good segue. Let's connect this to the science. Why does this spillover happen? We need to talk about REM sleep, right?
Absolutely. REM sleep, rapid eye movement sleep, is crucial here. That's our main dreaming stage. And normally during REM, our brain sends signals down the spinal cord to basically paralyze our voluntary muscles.
That's the rematonia you mentioned.
Exactly, rematonia. It's a protective mechanism.
Stops us from jumping out of bed while dreaming we're flying or something.
Precisely. Stops us from acting out our dreams. And normally we're totally unaware of this because we're fully asleep.
So sleep paralysis is essentially that paralysis sticking around after our mind wakes up.
That's the basic mechanism. It's a glitch, a disruption in that smooth transition between REM sleep and full wakefulness. Consciousness returns, but the muscle atonia hasn't switched off yet. For a while, the model was just awake brain, paralyzed body.
But you mentioned newer research adds a wrinkle to that.
Yes, this is really interesting stuff from the sources. Recent EEG studies, actually measuring brainwaves during sleep paralysis episodes.
Right.
They suggest the brain isn't fully awake in the typical sense either. It's actually showing patterns, especially these theta rhythms, that are characteristic of dreaming sleep, even while the person feels conscious and aware.
Okay, hang on. So it's not just an awake mind trapped in a sleeping body. It's more like consciousness is flickering on while the brain is still partly in a dreaming state and the body is paralyzed.
That seems to be a more accurate picture emerging from this research, yes. Consciousness comes online, but it's arising within a state that still retains key features of REM sleep, including the capacity for dreamlike experiences and the muscle atonia.
That makes so much more sense for why the hallucinations feel like dreams bleeding through.
Exactly. It provides a much better neurological basis for those vivid, often bizarre hallucinatory experiences.
And what's causing this glitch at the neuron level? Any theories?
The sources point to potential imbalances in the groups of neurons that regulate our sleep-wake cycles. Like maybe the sleep-on neurons, particularly those using acetylcholine, are overactive,
Okay.
while the sleep-off neurons, maybe those using serotonin, are underactive. This kind of imbalance could mess up the timing of the transition out of REM.
And the paralysis itself. What chemicals are normally hitting the brakes on our muscles?
The key neurotransmitters for that muscle inhibition during REM are GABA and glycine. They're the brain's primary inhibitory signals. In sleep paralysis, it seems there's a lack of synchrony. The signal to stop releasing these neurotransmitters and release the muscles doesn't perfectly align with the return of consciousness.
So the brakes stay on a little too long.
Essentially, yes.
And did the sources mention specific brain areas linked to those weirder sensations like floating or the out-of-body stuff?
They did. There's speculation about the cerebellum, which handles balance and coordination. Maybe brief spikes of activity there could cause a floating sensation. And the vestibular nuclei in the brainstem, which are strongly tied to our sense of motion and spatial orientation and are known to be active in REM.
Right.
They are also implicated, particularly in those vestibular motor type hallucinations, the OBEs and spinning feelings.
Fascinating. This brings up a question. Can you inherit this? Is there a genetic component?
Yes, definitely. The research highlighted in the sources shows a significant heritable link. Having a family history increases your risk, and twin studies strongly suggest a biological vulnerability.
So those slight imbalances in brain chemicals or neuron activity we talked about, they might run in families.
It suggests that, yes, a potential genetic predisposition towards these subtle disruptions in the sleep-wake regulatory systems.
Okay, so genetics plays a role. What about other factors? What makes someone more likely to experience sleep paralysis, according to the sources?
One of the biggest and most consistent risk factors is simply insufficient sleep or sleep deprivation.
Not getting enough hours.
Right. Most adults really do need that 7 to 9 hours regularly. Falling short significantly increases your risk.
And it's not just the total amount, but the pattern, too.
Absolutely. Irregular sleep schedules are another major trigger. Inconsistent bedtimes, inconsistent wake times.
Like shift workers, students, people with jet lag.
Exactly, those situations. Shift work, cramming for exams, frequent travel across time zones, they all disrupt the body's natural rhythm.
And why does messing up your sleep schedule make this REM spillover more likely?
The sources explain that poor sleep, whether it's not enough or just erratic, throws off your body's internal clock, the circadian rhythm, and the delicate regulation of your sleep stages, including REM. The brain's ability to transition smoothly between sleep and wakefulness is really sensitive to consistency. When your schedule is all over the place or you're sleep deprived, the control mechanisms for REM can become unstable, making it more likely for that atonia to linger inappropriately when you wake up.
So inconsistent sleep basically confuses the control system.
That's a good way to put it. It destabilizes the normal transitions.
Are there underlying health conditions linked to it as well?
Yes, definitely. Narcolepsy is the classic example. Sleep paralysis is actually one of the core symptoms for many people with narcolepsy.
How many?
The sources mention estimates of 25% to 50% of people with narcolepsy experience it. Their brains inherently struggle with regulating sleep and wakefulness, and they often enter REM sleep very quickly, even during naps.
Makes sense. What about mental health?
A strong association there, too, especially with anxiety disorders like generalized anxiety disorder, panic disorder, and notably post-traumatic stress disorder, PTSD. Yes. One review mentioned in the sources found significantly higher rates, even up to 60% prevalence in psychiatric patients, particularly those dealing with PTSD and panic issues.
Given the fear involved in sleep paralysis itself, I can see how anxiety or trauma could potentially make it worse, or vice versa.
It could certainly create a difficult cycle. Other links mentioned include conditions like high blood pressure, obstructive sleep apnea, and also chronic issues with alcohol or substance abuse.
And you mentioned sleeping position earlier.
Right, just sleeping flat on your back. The supine position seems to be associated with a higher likelihood compared to sleeping on your side or stomach.
Okay, so if someone is experiencing this, especially if it's frequent or really scary, when should they think about getting medical help?
Well, the diagnosis itself is usually made just based on the person's description of what happens. A sleep diary can sometimes help track patterns, too.
Do they need, like, a sleep study with all the wires?
Usually not, no. Those specific tests like a polysonogram, the overnight sleep study, or the MSLT daytime nap test, they aren't typically needed just for isolated sleep paralysis.
When would they use those tests then?
They're mainly brought in if the doctor suspects an underlying sleep disorder is causing it, like narcolepsy, or if there are other complicating factors they need to investigate. The tests are more about finding the cause, if there is one, not just diagnosing the sleep paralysis event itself.
Got it. So what are the actual criteria for thinking, okay, I should talk to a doctor about this?
The guidelines highlighted in the sources really focus on the impact it's having. So you should consider seeking help if the episodes are happening frequently and causing you significant distress or anxiety.
If it's really upsetting you.
Right. Or if you find yourself feeling really anxious or fearful, specifically about going to sleep because you're worried it might happen again.
That anticipatory anxiety.
Exactly. Also, if you're experiencing chronic tiredness or excessive daytime sleepiness, that seems linked to the sleep paralysis, maybe because you're avoiding sleep or your sleep is disrupted by it. And of course, if there's any reason to suspect, it might be a symptom of something else, like narcolepsy.
So it really comes down to how much it's affecting your mental well-being and daily life, maybe even more than just how often it happens.
That's a key takeaway from the clinical perspective in the sources, yes. The focus is often on managing the distress and improving quality of life.
Okay, that's really helpful guidance. So for managing it or trying to prevent it, what works?
Well, the good news, according to the sources, is that often no specific medical treatment is actually needed. Sometimes just understanding what it is, learning that it's a known, generally harmless neurological event can be hugely reassuring.
Taking away the mystery and some of the fear.
Exactly. Knowledge can be powerful in reducing anxiety, but the main strategy for management and prevention really boils down to optimizing your sleep hygiene and lifestyle.
Back to those sleep basics.
Pretty much. The goal is to stabilize your sleep-wake cycle and promote healthy, consistent sleep, which makes that REM spillover less likely.
So what are the top recommendations from the sources?
Number one is getting enough sleep, consistently hitting that 7 to 9 hour mark for most adults.
Consistency is key.
Absolutely. Maintaining a regular sleep schedule, same bedtime, same wake time, even on weekends as much as possible is critical.
Well,
Avoiding sleeping on your back if possible, try side sleeping, limiting stimulants like caffeine, alcohol, nicotine, especially later in the day, avoiding large meals right before bed.
exercise.
Regular exercise is great for sleep, but probably best not to do intense workouts within about 4 hours of bedtime. Creating a good sleep environment is important. Too dark, quiet, cool.
And screens.
Yeah, limiting screen time, phones, tablets, computers for an hour or two before bed is also recommended.
These all sound like good sleep advice in general, but the sources emphasize why they work for sleep paralysis specifically.
Right. It's because these practices directly help stabilize your overall sleep architecture, including the regulation of REM sleep. They make those transitions between stages smoother and more reliable, reducing the chance of the atonia lingering when you wake up.
Makes sense. Are there other approaches people find helpful?
Yes. Relaxation techniques, things like deep breathing, progressive muscle relaxation, mindfulness, meditation can be really useful for managing the anxiety that often comes with sleep paralysis. Less anxiety can lead to better sleep.
And therapy.
Cognitive behavioral therapy, especially CBT tailored for insomnia, CBTI, can be effective. It helps people identify and change those unhelpful, fearful thoughts and behaviors related to sleep and sleep paralysis. It helps break that cycle. Fear leads to poor sleep, leads to more episodes.
What about medication? Is that ever used?
In some cases, yes. If the episodes are very frequent, severe, and aren't improving with lifestyle changes or therapy, doctors might consider prescribing low doses of certain types of antidepressants.
Why antidepressants?
Because some of them have the effect of suppressing REM sleep. Less REM sleep can mean fewer opportunities for sleep paralysis to occur, but this is usually reserved for more difficult cases.
And crucially, treating anything else that might be contributing.
Absolutely vital. If the sleep paralysis is occurring alongside, say, diagnosed insomnia, PTSD, an anxiety disorder, or narcolepsy, effectively treating that primary condition is often the most important step in reducing or stopping the sleep paralysis episodes.
Okay. This whole phenomenon really does give us a fascinating look at human experience across different cultures and times. You mentioned the cultural interpretations earlier.
It's one of the most compelling parts of the story, I think. The core experience, paralysis awareness, maybe hallucinations, seems remarkably consistent across the globe. But the meaning people ascribe to it, that varies enormously based on cultural context.
And you said there are like over 100 different names for it.
Yeah, the sources mentioned identifying over 100 distinct folk terms for sleep paralysis experiences worldwide, which just shows how widely it's been recognized, even if not understood scientifically.
And historically, it was almost always seen as supernatural.
Pretty much, yes. Supernatural or metaphysical explanations dominated for centuries, and still do in many places.
Like the night hag. That seems to be a really common one.
It's Probably the most pervasive archetype. This idea of a malevolent entity, often female, sometimes old or witch-like, sitting or pressing down on the sleeper's chest, causing that feeling of suffocation and paralysis.
And we see versions of that everywhere.
All over the world. The sources mention Mokthi in Albania, Boba in Bengal, the Panafesh or Pantaffica in parts of Italy, the classic old hag tradition in Newfoundland, Canada. It's a very common motif.
What are some other examples from the sources?
In Egypt, it's often linked to attacks by jinn, which are spirits in Islamic lore. In Japan, you find beliefs about vengeful ghosts. Some Inuit traditions in Canada attribute it to spells cast by shamans.
And in modern times, especially in the West.
In more contemporary Western context, particularly the US, the interpretation sometimes shifts towards alien abduction, especially when the experience involves those out-of-body sensations or visual hallucinations of strange figures.
That comparison the sources made between Egypt and Denmark was really striking.
It really highlights the power of cultural narrative. In Egypt, with these strong, elaborate beliefs about jinn, sleep paralysis is often associated with intense fear. One study found around 50% of experiencers feared they might die,
Wow.
and the reported prevalence there is about 3 times higher than in Denmark.
And in Denmark.
In Denmark, where the sources suggest it's generally viewed more through a physiological or psychological lens, that reported fear of death during an episode is much lower, around 17%. And maybe the episodes are even perceived or reported as being shorter.
So the cultural story literally seems to shape the emotional intensity and maybe even the reported frequency or duration.
It strongly suggests that cultural criming profoundly shapes the subjective experience, the perception, the emotional response, how readily it's identified and labeled.
The story we tell ourselves about it changes how it feels.
It seems to, significantly. And we can trace this through history, too. The sources mention the first clear Western clinical description was back in 1664 by a Dutch physician who called it incubus, or nightmare.
Still using those loaded terms.
Right. But descriptions suggesting the experience exist even earlier, like in 10th century Persia, and explanations have evolved. By the 19th century in Europe, sometimes diet was blamed.
Like Scrooge blaming his ghost sighting on indigestion.
Exactly. Dickens captured that shifting perspective, and some literary figures might have drawn on it too. J.M. Barrie, who wrote Peter Pan, described something very like it, a sheet that tried to choke me in the night, and explored themes related to loss of muscle control and sleep.
So the bottom line here is that sleep paralysis is this enduring, probably universal biological event.
Yes, rooted in our sleep physiology.
But how we understand it, the stories we tell about it, have changed dramatically, depending on the scientific, spiritual, and cultural ideas of the time.
Absolutely. The narrative around it is constantly evolving, shaped by culture.
So wrapping this up, what does this all mean for you, the listener? This deep dive has shown us that sleep paralysis is fundamentally a common and usually harmless glitch. It happens when that transition between sleep and waking gets a bit tangled.
Right. Your mind wakes up, but the normal REM sleep muscle paralysis hangs on for a bit. And sometimes elements of dreaming, like those vivid hallucinations, spill over into your conscious awareness.
And while it's rooted in biology, that rematonia, the brain chemistry, maybe even genetics, the experience itself is often made truly terrifying by those hallucinations and the sheer helplessness you feel.
That feeling of being trapped and vulnerable.
But importantly, just understanding the mechanics of it can really help reduce the fear. And managing it for most people comes down to focusing on good, consistent sleep habits.
And addressing any related anxiety or underlying conditions that might be contributing.
And maybe the most fascinating aspect we've uncovered is how sleep paralysis serves as this incredible example of a universal human biology being profoundly shaped by our cultural lens.
Yeah, giving rise to all these diverse myths, folklore, and interpretations across different times and places. It shows how powerfully our beliefs can color our experience.
Which leaves us with something to think about. If our cultural stories and personal beliefs can so dramatically influence how we experience something as fundamental as the boundary between sleep and wakefulness, how else might the narratives we live by be shaping our perception, our experience of reality itself?